Welcome, everyone. I think we're up to a good number of people. We hope everyone enjoyed lunch. To get us started, it's my honor to turn the program over to Dana-Farber trustee Nancy Gibson and Dana-Farber trustee Jen Perini.
Hello, I hope you're all enjoying today's presidential symposium. My name is Nancy Gibson. I'm a member of the Board of Trustees. I joined the board over 20 years ago. And as Carol Bowen so beautifully shared with all of us earlier today, Dana-Farber is part of my family too. We came to the Institute in December of 1993. Our son Craig was 7 years old and was diagnosed with acute lymphoblastic leukemia. He had 26 months of chemotherapy and radiation. He is now today a thriving 35-year-old, happy, healthy young man, thanks to the amazing care of his doctor, our beloved dear friend, Dr. Steve Sallin. My father was also treated at Dana-Farber by Dr. George Dimitri in 2000, and he was diagnosed with a rare cancer, chondrosarcoma. Unfortunately, my dad lost his battle, but we knew he had received the best care in the world at Dana-Farber. And we and my family are very grateful for that. My husband was diagnosed with head and neck cancer in 2015. He was cared for by yet another amazing doctor, Dr. Robert Haddad, who has walked with us every step of the way. And in June, Craig had his 5-year checkup and he is cancer-free. So we are forever grateful for all the miracles at Dana-Farber each and every day. So pleased that we're able to host this breakout session, and I'm just going to invite Jen Perini to share a few words with us. Also, her story.
Thank you so much, Nancy. Thank you. And thank you all so much for attending this particular breakout session. It is absolutely star-studded and full of really exciting and hopeful findings. I hope you've been able to attend the morning sessions, and that if so, you're as inspired as I am. My name is Jenny Perini, as Nancy said, and it's been an honor to be a trustee here at the Dana-Farber. I have a strong family connection as well to the Dana. My grandfather, Lou Perini, was one of the co-founders of the Jimmy Fund through his ownership of the Boston Braves baseball team, the other Boston senior baseball team. But I really came to know the Dana when my brother David was diagnosed with Ewing sarcoma when he was 18 years old. And over the 8 years of treatment until David's death when he was 26, we became incredibly close to the doctors and nurses on his team, to the point where they truly were family. I will always feel grateful for how much they cared about David well beyond the treatment of his disease. I'm especially excited about today because, like Nancy and many of you, I've seen cancer affect people I love at all different ages. In addition to David's diagnosis as a teenager, my niece was recently diagnosed at age 32 with stage 4 colon cancer. My dad had prostate cancer in his 70s, and my aunt in her 60s was just diagnosed with pancreatic cancer. All of them either were or are currently being treated at the Dana-Farber. Truth be told, I wish none of them had ever have reason to be a patient here, but I feel so fortunate that this is where they've received care. Everyone I've known who has been treated here talks about being seen and heard in a way that transformed their care. They're not just patients, they're human beings. So on to today's session. While nothing can replace being in a room together, we're hoping to replicate that in-person energy as much as possible, but we're really looking for your engagement in order to do this. To that end, I'd like to ask Erin McVeigh, who is the Assistant Vice President of Donor Relations, to come on now and give you a brief overview of how to use this platform to ask questions. And please don't be shy. The more interaction we have, the better the event will be. Erin?
Thanks so much, Jen and Nancy, and thank you again for your leadership of this event. And to all who are participating today, we really appreciate you taking the time to learn and engage with us. To that end, I think we have one slide. Shauna, if you could put up this slide to just help guide you around the new virtual environment that we find ourselves living in. So first, just as far as the chat function, if you look on the right-hand side of your screen, you should see a box that says chat with two icons underneath it. The first icon is for comments. So that's a great way to connect with one another, to share your feedback. And then next to that, the question mark is a great way to ask presentation questions from our presenters. This will be questions that go directly to our presenters. We'll be helping them to navigate to make sure we're answering as many as possible live, and those we don't get to, we can address after today's session. Finally, a great feature of this breakout room is the opportunity to come in live. So if you would like to come on video and turn on your audio and have a discussion, again, to the point of we're trying to replicate an in-person event as much as possible, then you'll see the icon at the top of your screen that looks like a person raising a hand. So hit that icon, and then on the top of the left side of your screen, you'll see a video camera and an audio. You'll have to click those so that they're on, but note that once you click those, you still will not be live. It will be on our side to bring you live into the conversation. So even if you hit those by mistake, those two icons, the camera and the microphone, you will not be able to be seen or heard until we bring you into the conversation. So we'll know to do that by having you raise your hand. And with that, I encourage you again to use that chat function if you have comments. And I'm also going to turn it back over to Nancy to continue on with our introductions for today. Thanks again.
I invite all of you to introduce yourselves through the chat function and consider sharing one or more of the following: the name and your name and the number of years attending the symposium, an area that is, or a topic of that you're most interested in, and a key takeaway from today's morning session.
Thanks, Nancy. As we've said, today's session is focused on how Dana-Farber specializes in cancer care across all ages. We'll have two panels. The first panel will focus on genetic predispositions from both pediatric and adult perspectives. The second panel will address how Dana-Farber supports young adults who are navigating cancer from those in their adolescent years to their 20s, 30s, and 40s. Now I'd like to turn things over to our first panel moderator, the amazing Deb Schrag, Chief of the Division of Population Sciences, and Deb will introduce the first panel.
Good afternoon. Thanks to all of you for joining, and we wish we could all be in a room together, and we're going to try to make this work, notwithstanding the challenges of this brave new world we all find ourselves navigating until we have technology to better cope with coronavirus. So it is my great pleasure to introduce two superstars, Dr. Lisa Diller and Dr. Benjamin Ebert. They are both going to speak on this panel about living with cancer risk and how to navigate genetic predisposition to cancer. So a few big picture framing comments. We have learned that approximately overall 10% of cancers have clearly established heritable components. That is a genetic susceptibility that we can test for and identify. We are working very hard at the Dana-Farber to figure out how to integrate this into the routine care across the lifespan. So for all our pediatric patients and all our adult patients and their families. And to describe this really vibrant, exciting research agenda to you further, Lisa and Ben have agreed to share their work. I hope you'll pepper them with questions, lots of challenges raised by this exciting research. So a little bit about Dr. Lisa Diller. She is our Chief Medical Officer at the Dana-Farber Boston Children's Cancer Center and Center for Blood Disorders. Dr. Benjamin Ebert is the chair of the Department of Medical Oncology and the George P. and Jean S. Canellis Professor of Medicine at Harvard Medical School. Both Lisa and Ben are longstanding full professors and members of the faculty, and they are really thought leaders in this space. And I hope they'll give you a perspective that really transcends the lifespan. So again, please ask questions through the chat. Lisa will speak first, then we'll have a Q&A session, and then Ben will speak second. Lisa, take it away.
Thanks, Deb. Can you guys hear me and see me well? Because I can only see my slides right now. So someone.
Lisa, we can see you beautifully. And
thank you very much. Okay.
Yeah, we can see you beautifully.
Okay, thank you very much. I'm delighted to be here today, here virtually, hoping to see you all in person sometime soon, and to talk about my work and the work of many of my colleagues in genetic predisposition, in part kind of going back to my beginnings at the Dana-Farber. Here we have the New York Times of 1986. I'm sorry that on the front page there's a memory of a baseball series that we don't like to remember. But if you look down to the bottom, you'll see an article that was on the front page of the New York Times right when I was a resident, and got me thinking about what I wanted to do with my life. In 1986, what we knew is that some cancers ran in families, and there was one particular kind of cancer, a rare eye tumor in children called retinoblastoma, that seemed to have a very strong propensity to occur in multiple siblings within a family and through generations. And in 1986, a member of our faculty, Stephen Friend, was, along with colleagues at the Broad Institute, or what would become the Broad Institute, and at Mass Eye and Ear, was able to identify a gene that told us who was at risk and or that contributed to our understanding of the biology of that tumor and explained predisposition in a hereditary way. This is before we knew about BRCA genes, when people were just following big families with cancer but didn't have an explanation. And I want to show you this slide of a patient the parents have given me, or two patients. Parents have given me a permission to show you this picture. It's a really important picture to me because back in 1980-something, when I was a resident, I read this article and was training in pediatrics and thought, wow, we could use this to prevent disease. So the young man in the graduation cap is a young man who was diagnosed with retinoblastoma as a very young child, as a neonate. And when he was diagnosed, his disease was so extensive that he required chemotherapy and radiation, and eventually has very, very, very poor vision, is essentially blind, but cured of his disease. And he was found to carry this gene identified by Dr. Friend, one of our former trainees and former faculty members. So when his little sister was born, she was tested. Now rolling forward a couple of decades, she was tested for that gene and found to carry the same mutation, the same problem. But she was screened very rigorously by ophthalmologists and pediatric oncologists from the day of her birth onward. And when she developed that disease, the disease was suspected to be there, was found early, was treated with only laser therapy. She never required chemotherapy. She never required radiation, and she has perfect vision. This is a 30-year story of how we've turned our understanding of genetics into prevention of disease, but it is definitely a real phenomenon. Just to make sure we're all on the right page in terms of what I'm talking about, Ben will talk about some other kinds of genetics, but I'm talking about a kind of genetics like the BRCA mutations, where an individual might have a normal copy of one gene associated with the development of cancer, but an abnormal copy of another on the other copy. You get one copy from your mom, one copy from your dad, and you could have acquired or inherited a defective copy of a gene that puts you at higher risk for cancer. I think the most commonly understood or by the general public is the predisposition to developing breast cancer, but this is definitely true in children as well. And we use the term germline cancer predisposition to talk about these phenomena. So when we identify a child with a cancer predisposition, we often do that in the setting of a child who already has cancer. We diagnose that child with cancer and we ask ourselves, does that child have a predisposition? You heard about this morning about the genetic testing that's been going on at the Dana-Farber for some years now, where we've established that about 10% of children who have cancer, probably more as we go forward, have some underlying genetics that explains the development of that cancer. It helps us answer the question of whether the child's at risk for additional cancers. Are there brothers and sisters or other family members at risk? Does it change the way we might treat that cancer differently? What do we do to look for cancer early, and how can we prevent? So what we've developed here, first very slowly and now at a very fast pace, what we've developed is a pediatric cancer genetic risk program. This graph here shows you the growth of the program in terms of the numbers of patients we see. Patients are seen by pediatric oncologists, nurse practitioners, genetic counselors, psychosocial providers, and we use our research coordinating staff significantly to make sure that we learn from these patients in order to answer the questions that need to be asked in the decades to come. This program is now directed by one of my junior colleagues, June Kamahara, who has really developed this team and helped us grow at the fast pace that we've been growing. The support of donors like yourselves, the Rose family, the McKinsey family, the Perini family, in moving these kind of programs forward is significant. So a patient who's diagnosed with having a cancer predisposition syndrome may come in and get genetic counseling. We feel like every patient and their family needs to have education. It's enough of a psychological burden to have cancer in a child, but then add that other family members might have cancer risk, and so we try to provide psychosocial support. We do testing of family members, risk assessment, and screening and prevention. That's the journey for each one of our patients. We see this as a partnership, partially because as everything else at the Dana-Farber, the staff, the faculty, and the patients work together to make this place, the Dana-Farber, one of the world-leading institutions for cancer care, but also because it's a rapidly evolving practice. A genetic finding we find today might be reclassified tomorrow. Screening recommendations might change from this year to next year. So we really have to be in a sort of bound situation, being with our patients and their families to get them through this journey. We try to figure out, by doing genetic counseling, what the most important test to do would be based upon what you see as an example here of a family history. In this particular case, very suggestive of a syndrome called Lee-Fraumeni syndrome, again named after a faculty member, Frederick Lee, who I had the privilege of training under at the Dana-Farber. Once that syndrome was established and the gene connected to that syndrome was made, patients were initially checked just for a specific gene. Now that we have what we call panel testing, we can take a family history and then think about what types of genes might explain that particular finding and do overall panel testing for that family, broadening our approach and our hypotheses about what might be explaining the family history of cancer. Over the years that we've been growing, we've seen more and more patients and follow more and more patients who have been found to have positive germline testing. These are just a bunch of genes that you're seeing there that we've found to be positive in our patients, and they each have a different screening recommendation associated with them, different risks for the children at different ages, as well as their parents and siblings if we identify those mutations in the family members themselves. As we understand risk better, we can do more tailored screening so that depending upon the age of the patient, the way in which the family history has evolved, that might help us know how to screen that patient. What are the big questions in this field then? Who should get genetic testing? That baby that I told you about, or that young man that I told you about at the beginning who didn't know or didn't have a family history of that disease, retinoblastoma, should we be testing all babies so that that never happens to a child like him? What would be the implications of that, and how would we do that? If a mutation is detected, how should that individual get screened? We're still working on that, doing research that you heard about a little bit this morning, mostly focusing on the adult cancer risk, but also we're doing on the pediatric side, very extensive whole body MRI screening. What are the risks of specific cancers or precancers at different ages with children with different mutations? And how can we tailor screening to each age? One of the things that also got mentioned this morning is whether or not we can do blood tests and find cancer before it actually occurs. One of our talented junior faculty members at the Dana-Farber, a pediatric oncology, is doing this looking at circulating tumor DNA, basically taking DNA samples and looking for very, very, very low evidence of the presence of a tumor to be able to know that that child is developing a tumor, and then thinking about how we might screen that child more intensively. This is in its beginning stages. It is so important that the numbers of patients we have in the predisposition clinic, the genetics clinic, participate by giving blood samples so that we can really learn how to do this. We are also leading a consortium called the Edison Consortium, which stands for Early Detection in Syndromic Cancers. We have children who have these predisposition syndromes and study them on a regular basis. The big questions also focus on communication and support. What's the burden of information for families, parents? What does it feel like to be told that your child's at risk for cancer when they're a newborn, but that risk is 25% before age 20? That's 75% chance that they won't be developing cancer, and yet they're involved in a cancer center and getting testing. How do we help parents understand their risk? You'll be hearing from Jenny Mack later today, who's working on a project to really help adolescents and young adults understand their risk, going to them with their technology, using handheld devices and bot interactive technology to help them ask questions, be reminded, and understand their risk. And then what's the big question toward personalized care? And Ben may be talking about this as well. How can we prevent cancer from occurring at all? I want to show you a scan of a patient that I met in the inpatient unit when she came in as a young child, about 4 or 5 years old, with a CT scan that showed a giant tumor in her lungs. If you look at this CT scan, that big white thing in the middle is the heart, maybe pushed over a little to the left. Air is black, so outside the body, and where the lung is black. And then where the other lung should be, something doesn't belong. And that was a tumor called a pleuropulmonary blastoma. What we know about a pleuropulmonary blastoma is there's a very high likelihood in children with that disease that they have a germline abnormality or mutation that predispose them to develop that tumor in a gene called DICER1. Patient was tested and found to carry a DICER1 variant or mutation, and that led to testing of her family members, and her brother was found to have that mutation. So her brother went into our screening program. And what you can't see, because it's not coming up, is a relatively normal CT scan that shows two beautiful normal lungs and a tiny, tiny little cyst. That's a pre-tumor. I'm sorry it's not showing. The pre-tumor can be removed and prevent the tumor. Amy had to be treated with high-dose chemotherapy, radiation, and resection of her lung, essentially. Her brother, here he is, had a tiny little resection and is doing quite well, having developed no tumor at all. So this is an example of the power of genetic testing, like the patients that I showed you at the very beginning, the two patients with retinoblastoma, and these two patients who carry gene mutations that predispose them to lung tumors, that we can, by understanding the genetics, prevent tumors in children from occurring at all, pick up tumors early, and learn so much about the biology of tumors that maybe we can come up with prevention to stop cancer in its tracks. I think that's where I end. One more, I just want to re-show you this slide of how we're growing with a shameless plug for support. This is a program in need of a better name. We'd be happy to be supported by someone who finds our work incredibly compelling. It's a growing program. It takes a village of professionals and a significant amount of research to move the field. Thank you to those of you who have already supported this program, and I look forward to talking to anyone who would love to know more. And thanks again to all those talented people who I mentioned who work in the program. With that, I will stop sharing my screen and hopefully be able to answer questions.
That's great, Lisa. One question has already come in, and actually a couple through the question field, and we continue to encourage people to continue to ask questions as well. One that came up was, are you able to recommend, or are you able to, and do you recommend testing prenatally for siblings of pediatric patients? And Deb, I know you'll be seeing questions too, so feel free to chime in with others.
Oh, that's an excellent question. There are syndromes that if prenatally it was suspected that the child or the fetus might be carrying a mutation in a particular gene, that could be tested for. In fact, there are ways in which, using high-tech technology, one can create an embryo that actually does not carry the gene mutation, called pre-implantation genetic diagnostics. That can happen as well. One of my research interests kind of related to that is population-based testing for childhood cancer predisposition genes like the retinoblastoma gene that really change the care of children after they are born. And just like children have that little blood spot done called a heel stick that tests for some very severe metabolic disorders, have we reached the time in cancer genetics where a limited panel of pediatric cancer genes might be appropriate to add to that screening?
So Lisa, that was fantastic. We have another question in the chat, which relates to how you're integrating testing for genetic predisposition into survivorship care. So many of the fabulous donors who, you know, the loyal donors and folks who've attended the session today may have had family members who were treated many, many years ago and are not current patients, and the technology's really evolved. How do we make sure that those folks are able to benefit from, you know, the insights and progress? What is your strategy there?
These are great questions. Locally at the Dana-Farber, for patients who are still receiving care in the Perini Family Survivor Center and David B. Perini Jr. Quality of Life Clinic, we are reaching out from the genetics clinic to try to reach all survivors for them to have a genetic counseling visit. One of the questions, of course, is the sort of public health matter, that there are over 500,000 survivors of childhood cancer now in the United States. And how are we going to reach them all? A research study being done by one of my trainees and colleagues is trying to use telemedicine, even before COVID, trying to use telemedicine and telegenetic counseling to offer this kind of genetic assessment and genetic testing for people who are all anywhere in the country. I completely agree with you, Deb, that there are patients out there who were not and wouldn't have been aware at the time that they were diagnosed that these genetics were possibly explanatory for their cancer and that they should get back into care. That's a message that we're trying to get out. We hope to get that out to gynecologists, pediatricians, obstetricians, and primary care providers, where people are receiving care.
Great. Okay, I'm not seeing other questions, and I think maybe in the interest of time, we should move on to Dr. Ebert's remarks, and then we can perhaps, if we have a little additional time, take some questions to both of you at the end.
I have to go on to another breakout, so Ben, my apologies, and enjoy your afternoon, everyone. Thanks for your time.
Thank you so much, Lisa. We really appreciate it. Oh, Ben, you're still on mute.
List me as unmuted, but you hear me?
Now we do. Thank you.
Okay, great. Thank you. Thanks for the opportunity to get to talk to you a little bit today. One thing I just wanted to say as by way of introduction is that I think this is a great example of why the Dana-Farber is such an incredibly special place to be a patient, to be a researcher, to be a doctor, because genetics crosses many, many different domains. There are influences of genetics on pediatric oncology, on adult oncology, basic laboratory research, clinical research, translational research. And the thing that makes Dana-Farber so extraordinary is that we have world-leading researchers, world-leading clinical investigators, world-leading clinicians who give compassionate care to our patients. And we all are in a relatively small institution. We work together incredibly well. And in terms of genetics, a clinician may see a patient who has evidence of an inherited susceptibility to cancer. They talk to our colleagues in the laboratory. They may figure out what gene might be causing that. That leads to the development of a test that can be used in patients and then actually applied for the detection of cancer, for the identification of predisposition in families. And that's happened over and over and over again at the Dana-Farber. And it is an example of why the Dana-Farber is such an incredibly special place. Next slide, please. So I'm going to talk about age and cancer, and there are a number of factors that go into the development of cancer as we age, one of which is our genetics, another of which is our exposures. Some people, like Keith Richards, have been exposed to perhaps a few more exposures than others, but some people can be exposed to powerful carcinogens for decades without developing cancer, and some children can be exposed with minimal, can develop cancer with minimal exposure to carcinogens. So our development of ideas of how aging works and how the cancer development works depends both on increased understanding of genetics, the development of early stage cancers, and an understanding of exposures. Next slide, please. So I wanted to convey one aspect that's important in genetics, which is that genetics isn't an all or nothing thing. We tend to think about a really powerful genetic predisposition in some families, and those are the kinds often that lead to cancer in children. But there are also what we would think of as low penetrance alleles, so genetic predisposition that increases the risk, but only slightly. And that is an entire spectrum from minimal effects to massive effects. So in panel A here, you can see that that there's a spectrum of influence of germline predisposition as well as environment. And in B, in B on the lower left, you can see that some mutations are very highly penetrant, meaning that if somebody inherits that mutation, the likelihood of developing cancer is extremely high. The example here is CBP alpha mutations, which leads to leukemia in children. And then in C is the opposite, the development of cancer due to environmental exposure without any influence of genetic predisposition. And an example of that would be individuals who are exposed to the atomic bomb radiation. We've had the opportunity to work recently with investigators at Nagasaki who really first defined the leukemia risk and survivors of atomic bomb explosions, and continue to follow those patients in an amazing effort that's co-funded by the U.S. government and the Japanese government to care for individuals with those exposures. And in D would be an in-between where people may have some genetic predisposition, have some exposures such as radiation or chemotherapy, and may therefore have some integrated risk. Next slide, please. And another really important factor of genetic predisposition to cancer is that inherited predisposition to cancer is often not limited to cancer. Many of the genes, many of the mutations that predispose to malignancy have effects on other aspects of health. A classic example of that is a gene called RUNX1, another gene that was discovered here by Gary Gilliland and introduced into clinical practice. And we see many patients, in fact, some of the patients that he saw that identified it in the identification of this syndrome 2 or 3 decades ago are still patients here. And so some of these individuals do develop acute myeloid leukemia, but many of them develop platelet disorders, which platelets are the blood cells that help us stop bleeding, help form clots. And so many of the family members that were used to identify this syndrome really just had bleeding disorders and didn't develop leukemia. And caring for these families means caring for the malignant consequences of their genetic inheritance as well as their non-malignant consequences, and really understanding how they may be related. This is where our super intelligent and thoughtful physicians recognize syndromes where there's a combination of traits that are both malignant and non-malignant that may trigger a thought that this is a family that needs to be investigated for inherited predisposition, and really put it all together. Next slide, please. Now, how does cancer actually develop, independent of what is inherited in terms of risk? It doesn't happen in one lightning bolt, generally, of an event. To get cancer, generally, multiple mutations that are somatic, as was introduced in the last talk. Somatic mutations are the mutations that happen during the course of our lifetime. And it's usually not a single mutation in almost all cancers, not a single mutation that causes cancer, but the sequential acquisition of multiple mutations. And that may take place over years and likely decades in many cases. One of the questions that patients almost always wonder when they develop cancer is, when did this start? And that's not an easy question, because the first mutations that occurred may have happened many, many years ago. And then the second and the third and the fourth mutations may have happened a bit more recently, until the full complement of mutations occurred that led to the development of cancer. But we start to develop mutations in our cells from the beginning of embryogenesis. There are mutations that occur in utero. During embryogenesis. There are mutations that occur throughout childhood and throughout adulthood. And the vast majority of those mutations are of no consequence, or makes a cell die or is less fit and ceases to contribute to future cells. But occasionally, a particular mutation, a cancer-causing mutation, will happen in a particular type of cell that is capable of becoming cancer. The vast majority of our cells can't become cancer no matter what mutations they acquire. But if those mutations occur in a stem cell and a cell that can become cancerous, then it can lead to the beginning of a premalignant lesion. It can lead to a clonal expansion of cells. That means many cells that come from one cell that acquired that particular mutation. And those expansions of cells with an individual mutation are clones or populations of cells that we are now learning to detect. And so we are able to detect premalignant states on a level that we've never been able to detect before. My lab has worked on blood cancer predisposition and individuals who develop mutations in blood cancer genes. Next slide, please. Turns out that those clonal expansions, we call it clonal hematopoiesis or CHIP, is actually quite common. So by the age of 70, about 10% of everybody has a premalignant lesion in their blood. And that increases the risk of cancer, of a blood cancer, by 10 to 100-fold, and identifies a population of individuals that we might be able to prevent cancer in. Next slide, please. And in addition, just like I mentioned that inherited predisposition can lead to a risk of cancer and non-cancer health issues, CHIP, this premalignant lesion in the blood, actually leads to non-malignant disorders as well. And in fact, it turns out to be a major cause of cardiovascular disease. We're learning as well that it may contribute to lung disease, liver disease, kidney disease, and other diseases of aging. So this is a bit of a revolution, I think, of understanding how premalignant lesions, as we get older, may lead to a variety of health issues that we associate with aging, as well as predisposition to cancer. Next slide, please. And this is not limited to the blood. There's evidence in the skin, in the esophagus, in our lungs, and our liver, and other tissues that we become coated with premalignant lesions over time. This is a really elegant study looking at skin, where if you take tiny, tiny millimeter, sub-millimeter biopsies of skin and look for cancer-causing mutations, an older individual will be almost coated with tiny, tiny little premalignant lesions. And understanding how that contributes to changes in the function of skin with age, or even appearance of skin with age, and the risk of cancer is really at the forefront of our understanding of early stages of cancer now. Next slide, please. And so finally, just to sum up the talks from this session, inherited risk or genetic predisposition is part of how we think about risk of cancer, as well as exposures, and now the detection of premalignant states. And together, that can help us define the risk of cancer in an individual. And what we do with that information is potentially to customize screening when people get their normal screening tests, or do additional screening tests or blood biopsies. Can we detect cancer earlier and therefore treat it earlier and have better outcomes? And our holy grail now is to identify those individuals at the highest risk or who have premalignant lesions, and to prevent cancer altogether. And finally, when somebody does develop cancer, their genetic predisposition, their exposures, the other premalignant states that an individual has may all influence selection of therapy. And so ultimately, our precision oncology may integrate both germline risk, somatic mutations, exposures, and other aspects of an individual's health. And I'll pause there and be very happy to take any questions.
Thank you so much, Dr. Ebert. One question that did come in, it's a bit of a both looking back as well as looking forward. Could you talk about something that, 5 years ago in your work, you really didn't even think would be possible? And then from the looking ahead perspective, what are you most excited about as you look for the next, say, 5 years?
So, often what changes things so suddenly in research is technology. and data. And I think the thing that has been so breathtaking for a lot of research in genetics is the development of enormous data sets. So there are data sets like the UK Biobank, an NIH program called TopMed, which is giving all of us access to many hundreds of thousands of genomes from individuals that we are learning enormous amounts about genetic risk from. Whereas in the past, we might put together a group of patients, hundreds of patients in a big study, and sequence them and understand their genetics. Now we are able to look at hundreds of thousands of individuals, and the power to understand the effects of genetic risk are orders of magnitude more powerful. And that's been incredibly exciting to really understand genetic risk. Going forward, right now, this idea that we could detect an early cancer, a pre-malignant state, and prevent cancer is so tantalizing and so exciting. That is really something that we see is developing the technologies to identify the pre-malignant states in a clinical setting as well as a research setting, and figuring out what to do about those so that we actually decrease the burden of cancer ever occurring.
Thanks so much. I think we have probably time for another question. Then, unfortunately, like so many of these conversations, we could go on. In the Q&A, we have a question basically relating back to what Dr. Diller said. Dr. Diller talked about detecting a tumor early and removing it to prevent cancer. How would you prevent a blood cancer from developing?
Yeah, so that's a great question. So in a solid tumor or a solid tissue, if you identify a pre-malignant lesion, you can remove it. And that is the basis of preventing colon cancer from colonoscopies and removing polyps. Unfortunately, blood cells circulate everywhere, and so there's no surgical way of removing a clone. And so we need a drug. We need a pharmacologic treatment or an immunologic treatment to treat it. I think that taking a cue from other slow-growing cancers, the goal doesn't always need to be to remove it entirely. The goal may just be to slow down the development of cancer so that a 60-year-old individual doesn't develop cancer in the next few decades and not suffer from that cancer during their lifespan. So I think identifying individuals, either slowing progression or having a drug that decreases the advantage of that clone, decreases the likelihood of it progressing to a full-blown malignancy is the goal. Either using a therapy that leverages the immune system to attack that clone, or directly targeting that clone and the mutations inside of it.
Thank you so much, Ben. That was fantastic. So appreciated.
My pleasure.
Okay, Steve, are you going to introduce our next panel?
It would be my pleasure. Thank you very much, Ben. That was thoroughly enjoyable. I'm Stephen Salen, and I have the pleasure of introducing the next panel in this session. And I'm a pediatrician, pediatric oncologist. My field is childhood leukemia, and I'll introduce a little bit more about my interest in this afternoon's topic. And this afternoon's session is really how we navigate what we're calling this gap, bridging the gap. And it's really a gap between childhood cancer and adult cancer. And it's basically older adolescents and young adults in their third and fourth decades of life, their 20s, their 30s, into their 40s. And I might slip into some jargon calling it AYA, adolescent and young adult medicine. It's kind of a title that it's grown into. And to help us discuss this topic, we have selected a panel of superstars, and I don't see them, but I hope they're here. And are you here, Katie Janeway? Wonderful.
I'm here.
Oh, it's happy to see you. And Jenny Mack.
Hello.
And Ann LaCase.
Ann LaCase, we're just waiting, Dr. Partridge is going to be joining us in one moment, so.
Got it. Well, I will start with by introducing Katie Janeway and Jenny Mack, who are both pediatric oncologists. They have lots of titles as shown in your handout, but my relationship to them started when I had the honor and privilege of training both of them, which always is a special place to be. And Katie in particular in a strange way because her grandfather helped train me. That was a long time ago. Katie is the director of clinical genomics and sees children with solid tumors. Jenny Mack is our associate chief of population sciences, and we'll explain what that is for pediatric hematology and oncology. Ann is the director of the Dana-Farber and Mass General Brigham Fellowship, where we train our internists in cancer medicine. And Ann is a medical oncologist and internist. And Ann Partridge, who is coming, and I'll introduce her, and I'm sure you will hear from her momentarily. Ann is the founder and director of our program for young women with breast cancer. So each of them is going to work as part of a 4-person panel. I'm going to feed them 3 or 4 questions in the course of the next 40 minutes or so. And also, in addition to their discussions, invite your questions for them. And I'm going to start actually with introducing this from my own perspective in treating young adults with cancer. So this is a bit of a story. Can you show me my first slide, please, Aaron? Great. This is a story, like all stories, it starts with people. And the people who are part of this story, this came about really about the turn of the century, about 20 years ago now, it's hard to believe, when one of my late colleagues, Jim Nachman, who was a pediatric oncologist who studied childhood leukemia, and from the University of Chicago, and he was a national principal investigator for a study of the most common childhood malignancy called acute lymphoblastic leukemia. And his protocols were conducted at about 250 children's services across the US. Wendy was and is a medical oncologist, also from the University of Chicago. She takes care of adults with leukemia. And Jim's protocols covered patients from age 1 to 21, and Wendy's protocols in about 450 US adult leukemia services treated adults ages 16 to 70. And for those of you who are keen listeners to numbers, you will know, as shown on the next slide, Aaron, that the 16 to 20-year-olds were eligible for both of these studies for 5 years at the same era. And at one point, Jim challenged Wendy to say, let's look at these 16 to 20-year-olds. They're the same population, same disease, same era. And when they looked, they saw something that was stunning, because shown on the top curve here were the outcomes for the 16 to 20-year-olds treated by the pediatric group in these 250 hospitals in the country. 2 out of 3 of those 16 to 20-year-olds were cured, as shown by the flat line at about 65% here. That same population treated at the same time by Wendy's group, 1 out of 3 of those 16 to 20-year-olds was cured. And this was a real conundrum that people didn't understand. And I had the opportunity now about 15 years ago to compare these kind of results really around the globe. And shown right here are Jim and Wendy's studies. The dark blue curves, the pediatric studies, about 60% cured, and this orangey red bar here, the adults treated on the adult protocol, about 30%. And everywhere we looked, in France, where they had overlapping ages, the UK, the Netherlands, Scandinavia, everywhere we looked in the world was identical. And people scratched their heads and said, what in the world is going on here? So in the next slide, we basically set the stage for the next 15 years of research in this area and trying to untangle this knot. Was this biology? It shouldn't have been. This particular group really were the same. Was it the therapy they were receiving? Maybe it was different. And then there was this enticing sociology, and I'm sure Jenny Mack is going to talk a little bit about this when it's her time. But are we really different? Are the internists and pediatricians, as opposed to the patients or their treatments, really different? And it's a long story. I'm going to give you one of many explanations on the next 2 slides. My friend on the next slide, Aaron, my friend in Detroit, also a medical oncologist who treats adults, Charlie Schiffer, he said he was trying to sort out whether there are cultural or sociologic differences amongst us. He said the pediatricians wear these crazy ties and the straight medical oncology internists don't. I don't know about that. But this is what I found in looking at this over time. On my last slide, one of the things that's hugely different is shown on the last slide, Aaron, and that's the role of the mother. Here's a 29-year-old, whoa, there was a 29-year-old woman before she disappeared, and she is the mother of a child with leukemia. Can you bring back my picture, Aaron? There she is. And she's taking care of her child, and she's been inculcated with the rigor with which we want to treat, and she's been trained that we're going to be incredibly intensive in our approach, and she's going to do everything she can to make sure this guy gets his therapy delivered to him in a timely way. The same 29-year-old woman, not as a caretaker, but as a patient, gets the same disease, and her whole role here is different. And how we go about treating our 20-something and 30-something-year-olds turns out to have been quite different. And over the last 15 years, we've worked through this. We've changed this dramatically. And I will stop by saying that when we started looking at this systematically, we formed a group at Dana-Farber with our adult leukemia doctors, Rich Stone and Dan D'Angelo in particular. And when we recognized these differences, in the first 7 or 8 years, we doubled the survival of young adults with acute lymphoblastic leukemia, and we continue to make strides even today. So we could stop sharing this, and we can start sharing one another here. And good, we have Anne. Welcome, Anne. It's nice to see you. I've introduced you already, and we're going to give you an opportunity to speak. So as I just want to remind everybody, each of the 4 panelists are going to take a stab at the same questions that I'll toss out there. And the first one, I really want to ask each of you who are really expert in your own fields what your area of focus is. And if you could say a few words about what has attracted you to this adolescent young adult, and just the way you appear on my screen. I'm going to start with Katie, but then I'll let you guys sort of choose your own order after that. Katie?
Hi, everyone. So let me know if you can't hear me well. I'm Katie Janeway. I'm a pediatric oncologist and a sarcoma specialist. And sarcomas are tumors of bone and muscle and the other tissue that kind of holds your body together. And they're a collection of rare, pretty poorly understood cancers, and they affect primarily adolescents and young adults, especially the bone sarcomas, which are the ones I really focus on. What attracted me to this area is that progress has been incredibly slow for sarcomas. We haven't seen the same improvement in cure rates and the same sort of rate of new treatments coming into the clinic. And in the most extreme example of osteosarcoma, which is the most common bone sarcoma, really my primary focus, in 40 years, we've been treating osteosarcoma the same way. Absolutely no change. And Dr. Salin mentioned that he trained me. And in fact, one of the first patients we met together was a young girl with osteosarcoma. And he said, you know, this is the same treatment that I gave when I was in training. And I'm still teaching my fellows the same treatment. So really, that interest in sarcoma led me into genomics, or the study of the kind of gene changes that underlie or drive a cancer, as a way to better understand these cancers and what was sort of making them tick, as a way to define cancer subtypes, and in some cases, as a way to identify more effective and less sort of toxic treatments. I'll pass it along. How about I call out the next person? Anne, why don't you go next, since you're next on my screen?
I presume it's Anne LaCase here. Hi, I'm Anne LaCase. I am a lymphoma specialist here at Dana-Farber on the adult oncology side. And my research focus and the disease I really enjoy treating the most is Hodgkin lymphoma. And it's actually quite a contrast to what Katie's just talked about in the sense that the vast majority of our patients with Hodgkin lymphoma are actually cured of their disease, but our therapies can lead to late toxicities that can have an enormous impact on the quality of life and can lead to secondary cancers, particularly with radiation being part of the therapy. And I think trying to balance the wanting to cure the disease with limiting late effects in this particular patient population who are so vulnerable. You know, Hodgkin is the most common disease we see in this age group. Many of the patients are in their early 20s, just as they're trying to launch their lives. And all of a sudden they're in our clinics and we're trying to figure out not only what is the best treatment right now, but how are we going to care for that patient for his or her whole life. And I think the therapies, we still use standard chemotherapy up front with Hodgkin lymphoma, but there have been some really amazing advances over the past few years, some of which came directly out of work done here that we'll probably talk about in a moment. But it's just a very rewarding group of patients to treat.
I'll jump in next. I'm Jenny Mack.
Thanks, Jenny.
I'm a pediatric oncologist, and my clinical interest is in solid tumors, but my research interest is in communication between patients and their clinical teams. So everything from, how do we deliver information about a diagnosis, which is such a life-changing experience for patients, to how do we engage them in the decisions that they need to make? How do we help them with those decisions? And how do we support them through that whole period of treatment and beyond? And so when I first started doing this as a pediatrician, I was studying parents because those are the people who we talk to the most as pediatricians. And somewhere along the way, I got interested in studying communication experiences of adolescents and young adults. And it's been one of the best choices that I've made from a research perspective because it's been so much fun and so interesting. You know, this is a population where young people in this age range are figuring out who they are, what their identities are, what's important to them in life, and how they're going to navigate life that's moving from being in a family with their parents to being independent young people. And everyone is different, just like every patient we see, but there's just so much to learn with each patient, and it's just been such a wonderful, wonderful population to study and learn from over the years. So it's been a really kind of a gift to me to get to study this group. I'll move on to Ann Partridge.
How do I get myself?
You're on.
Thank you. I'm like, I thought somebody else was controlling that. The other Ann. I appreciate that. Thank you all. So I was drawn to this as a young breast cancer doctor working in the trenches, seeing patients, and in adult oncology, the adolescent and young adult patients in breast cancer are a relative minority, representing, depending on how you define young, somewhere between 6 and 16% of the population. And yet I found that they were the patients that were pulling on my heartstrings the most, both from the experience of the disease in terms of its risks and the morbidity and the mortality. You were seeing young patients dying, quite frankly, which is hard at any point in one's career, but particularly when you're first starting out in oncology. And the younger patients also were suffering the most, even when they were highly likely to be cured, both from the treatments in many ways and from the non-normative experience of going through cancer at a tender young age. And with that, I personally started looking into it more and realized that young age was actually a predictor of risk of death from breast cancer. And there was a real age disparity in terms of survival from breast cancer, which was even more enhanced in young African American women for lots of different reasons, both disease and access reasons. And so that really drew me to, okay, this is a disease problem and societal problem, and this is also an in-person, patient-to-patient problem. Our younger women are more likely to suffer after a diagnosis of breast cancer. And then on a personal note, right about as I was starting to delve into this from a clinical and research standpoint, I got a call from my then 30-year-old best friend from high school who had a lump. And you can tell the rest of the story, and I'm proud to say she's very happy to say she's alive and well, and we're both well beyond 30. But that kind of allowed me to see her experience not as necessarily a doctor, but as a friend. And she had a highly curable, very treatable breast cancer, as most breast cancers, many will be, even in young women. But this one, very treatable, very curable, but had significant ramifications for the rest of her life. And the decisions that came up, which were like, how do I live with no breast? How do I mate with no breast? How do I have children in the future? Were just so without answers. And so I made it part of my passion in life to try and help find those answers for our young patients. And I'll pass it back to Steve.
Wow, yeah. Just listening to all four of you reminds me, we are blessed to have one another. we really work in an amazing community. I think it makes me feel this distance that we're living with today more acutely than I felt it in a long time. But the other thing that is very clear that I don't know if it's unique to Dana-Farber, but it certainly is important to Dana-Farber, is that we work in this incredibly collaborative institution. And while we have some age group separations amongst the pediatricians and internists, clearly in this population, we cross lines. And I wondered if you could comment from your own perspective on how the Dana-Farber's setup, if you will, our culture, how it is sort of best suited to handle this young adult population, and how it compares with others of our peer who obviously see adolescents as well, but I'm not so sure programmatically how it goes. Katie, you have some experience with others?
Sure. I'd love to share just one brief anecdote. So I mentioned osteosarcoma as a major interest and sort of the lack of us having newer therapeutic approaches to osteosarcoma. Well, I'm very fortunate to work at Dana-Farber, where we are able to develop some of the science to help us understand what new drugs to study in osteosarcoma, and then to have the support of an institution that really knows how to run clinical trials, to be able to initiate an investigator-initiated trial, meaning I'm the lead investigator. With two drugs, olaparib and ceralasertib, which are newer sort of targeted therapies. Actually, this class of drugs were mostly developed for breast cancer, into a trial for osteosarcoma patients. And what's unique about Dana-Farber that sort of helps in this endeavor is that we are able to collaborate with the medical sarcoma clinic, both at Dana-Farber and at MGH, to open this clinical trial, which will expand the group of patients who are able to access it and reach into medical and pediatric clinics. And then also to our pediatric and medical oncology clinics at other institutions. And so in a rare cancer like this, I mean, collaboration not only within our own institution across medical and pediatric oncology, but also to other institutions outside of here who are also able to do that is so essential. And there are very few places actually where this is possible.
Yeah.
So I would echo that, and I think what is really nice about being at a place like Dana-Farber is that we have a pediatric and adult service that are basically in the same connected buildings. So we see each other and we talk to each other, and I think over the past couple of years I've been able to work with Lindsay Frazier as we try to think about how we're going to impact adolescent and young adult patients. And now we have this group, including Anne and Jenny and lots of other people who are really focused on this. And I think because of the culture of this place and everyone's willingness to collaborate and think about what's best for the patients, it really, we're making strides. I think our patients who are treated on the pediatric side and unfortunately have a recurrence, those patients need to come to the adult side. And I think having a warm handoff where we know each other and we can reassure patients and families that we all have the patient's best interests in mind. In addition, all of these diseases are relatively uncommon compared to the big solid tumors that we see in adults. So we have to do these clinical trials jointly, and we have to think together about, if we can ask only a limited number of questions because we have, a small number of patients, we have to think about that really carefully, and we need to have the buy-in of all of the stakeholders. And I think that's something that works really well here and makes us unique compared to a lot of other institutions.
Yeah. Jenny?
I would echo what Anne and Katie just said. I think that we're uniquely positioned to learn from each other in an institution like this, where we work in proximity to one another and our priorities are aligned to take the best care of patients that we can, to find new cures, to make the experience of care the best that it can be. And so for, both in terms of clinical care. I would say I learn from my colleagues on the adult side all the time. I often share patients with them or consult them for patients, and have done shared second opinions and things where I learn a lot, both medically and also in terms of the ways that they take care of patients. And I think they would say the same. And then from a research perspective, also, we have this great opportunity where we have, again, this alignment of goals in terms of finding the best ways to take care of the patients in the future. And I found that my colleagues here really come together around those goals in a way that that helps us all to do better with our research and with our patient care. So it's, I think that kind of collaboration has been one of the best things about working here. One of my mentors always advised me to work with people I like, and it's really easy here. I work with the most wonderful people, and I get to learn from them and do better work because of them.
An underappreciated facet of our life.
It's true.
Yeah. You're muted again, Ann. There you go.
Okay, good. I would only add that, and of course I agree with everything that's been said, that I think Dana-Farber is also unique in that they invest, and you all who are listening, so thank you, invest in us. They invest in people with good ideas that have a passion about fixing, not tolerating the status quo, and fixing a problem. And I'll tell you an anecdote. Years ago, when we were starting, I was starting my interest in young women, and Eric Weiner came to me and he said, you're really interested in this from a research standpoint. I have a donor who wants to support this programmatically because she was a young survivor who, felt like things could be better. And I said, absolutely, they could be better. And the rest is history. We wrote a proposal. We put our young women's program together. It's a thing now. And there are young women's programs that try and emulate our program all over the world now. And we recently, the real success of this is not only just growing a program that's supporting patients, but we're doing research through this program, including initially sponsored by philanthropic funds for seed, preliminary data. And we just wrote, along with Deb Schrag, who I think is on our panel with us or was on the panel before, we just got a U01 from the government to do basically a virtual young women's program for young survivors. And so to me, that's what we're all looking for. We're all looking for trying to take the research from the little test tube of Dana-Farber and then scaling it up, whether it's from, the true bench or the healthcare delivery bench to bedside to get out into the community. And I think Dana-Farber is a very unique place that supports people to do those things.
Yeah, well put. I think it's not well appreciated how unique we are. I mean, in the treatment of childhood cancer, clearly one of the nation's great places is St. Jude down in Memphis. But I can tell you that if you're over 18, you're off their radar. So that's taking the only place in the country that's exclusively childhood cancer, and they're out of this whole area, which we think is so critical to moving the field. And let's face it, there are no diseases that begin and end at age 18. And even at other cancer centers, this is a pretty hard thing to put together. And the fact that, we sort of have lunch together, and in my own relationship with the adult leukemia people, I mean, they formed a whole consortium, and then once or twice a year, our adult and pediatric clinical and research consortia, the research was in common, would really meet together. And it was really unique. All of our collaborators from across the country just had no other, even though they were from significant cancer centers, had no other opportunity like that. And I don't even think we realized how unique it was until sort of sat together and ate together. Always helps. I'm missing that in this format. I have another query to put before you to think about, because this field is relatively new. And the question is, if you thought about this whole endeavor 5 or even 10 years ago, what part of today's standard of care, if you will, wasn't even possible? And what do you think were the actual things that closed this gap for all of us? Katie?
Yeah, I guess I'll start again. So I think my co-panelists will know
I'm
what
just
I'm
going
going
to cross my screen. Sorry.
Okay, no worries. For me, what's really different today is that we sequence every young person's cancer and almost every young person's germline to look for cancer risk, which I know was talked about some on the in the prior panel. And you might think, how does that relate to adolescent young adult cancer and what we've been talking about? Well, to be honest, precision oncology came early and then sort of went in pediatric leukemia, then kind of went to medical oncology and came back to us. And it's really this unique relationship between where there's a really great pediatric oncology clinical and research program in the context of a cancer center that allowed us to really lead in showing how important it is to bring precision oncology and tumor profiling to younger patients as well. It was really, we were able to use the platform that was sort of built around lung cancer and other adult cancers for precision oncology and really make use of that platform, the Profile Project, in younger patients, and really led the way in showing that this was important to do in young people as well. So it's an example of how this fluid nature and relationships between the those of us caring for and doing research in the younger patients with the relationship that we have with those caring for and doing research in older patients is so impactful.
Yeah.
So the other, really big bucket of advance that's occurred over the past few years in oncology in general is immunotherapy, and I think immunotherapy in Hodgkin has been a real home run. And much of that work of dissecting out the biology of Hodgkin's, which is just a very unique disease, was done by Margaret Shipp here, and she identified that the chromosome in the tumor cell led to the expression of these immune checkpoints on the surface. And Hodgkin lymphoma has better response rates to immunotherapy than any other disease out there, and that was really defined here. And then even the icing on the cake is the fact that Gordon Friedman, one of the scientists here, was one of the people who described this as a target. So how exciting is it to be at an institution where the biology and the therapy sort of coalesce in this patient population where, we still need to do better and we don't want to use radiation, and occasionally patients do relapse, and these are people who we want to have long, healthy lives, and in comes immunotherapy, and it's been such a game changer, and we're just beginning to look at who needs it up front and how can we best use it in our patients.
Kenny, got any ideas about where this would be 5 or 10 years ago?
Well, I think one thing I've seen change over the past years is the way that we take care of patients, that we're becoming more and more focused at making the patient the center of care and making their experience the best that it can be in this incredibly difficult life circumstance. And so when that comes to adolescents and young adults, I think a lot of the things we've learned have been about helping them to voice their opinions, making sure that their care providers understand what's important to them in life and in their care, and making sure that their care really reflects those values. And those things might seem obvious, but I think that, we're still learning about that. And more, I think our care system is being designed to embrace that and reflect the importance of those values. And so I've seen that change, and I hope we'll continue to see that change over the years to come, so that we can help support patients through this kind of time.
Great. Yeah.
So I would say the big difference over the past decade that I've seen in the area of breast cancer in young women and survivorship in general for young adults is a much greater attention to fertility and the potential for infertility from treatment, and not just an awareness of that, but research that's been done, including at our institution, national and international guidelines that have attended to that are saying, this is a really important thing. So what if a person is cured of their cancer? You also need to pay attention to, what the rest of their life is about. And so I think that's where we've seen a real change in the mentality towards the treatment of cancer. And pediatrics was well ahead of the adult oncology of the world. And I think that it's been bridged in terms of thinking about survivorship for the AYAs in particular. And we're trying to also bring this to the greater adult population. But I think we've seen a big shift in the thinking around how we care for adolescent adult cancer survivors around, infertility is a good example. It's not just good enough to be alive. We want people to thrive.
Interesting. When you think about it, there is no such thing as long-term survivorship in childhood cancer, because the long-term survivors of childhood cancer are by definition adolescents and young adults, and these days getting to be not so young adults, which is a good thing. But our programs, it took a while before we recognized that survivorship really needed the expertise and care, really, of not of pediatricians, but of physicians who are trained to take care of this age group. It's a subtle change, but you've all been part of it. So clearly, very important to us when we have a session like today is the recognition of and the appreciation of the philanthropic side of all of this. These programs obviously don't exist without the people who recognize their importance and support us. And this takes me to a question, again, for each of you, and I'll let you do your own order. I don't want to put Katie on the spot every time. Of whether you have any anecdotal experience or experiences where you can kind of put your finger on an enlightened donor or the role of philanthropic largesse, if you will, that's really made this happen in a way that it probably otherwise either would not have or would have taken much longer. And I can think of yours already, Katie. As I'm speaking, I'm thinking of yours.
Yeah. So I'll go first. It's totally fine. I did love Ann Partridge's example of sort of a program being, started with donor funds and then really becoming something that people look to as a national standard and then getting grant funding. And I would say, for me, it's a very similar experience. Our initial exploration into precision oncology and genomics and cancer for younger people was really entirely supported by philanthropy. And a large portion of that still is supported by philanthropy. But what ended up happening is people recognized the importance of, sequencing or what we call tumor profiling and trying to use that information to either to sort of select clinical trial therapies. And that ended up being a sort of national trial supported by the NCI and run through our national pediatric cooperative group called the Children's Oncology Group. And I ended up having a enroll in that primarily because of the example that we set here at the Dana-Farber. And so I do want to tell just one small patient anecdote, actually, just to show how impactful that donor support can be for an individual patient. This is a different kind of story than I usually tell. I usually tell a story about finding a gene, a rearrangement or something that has a perfectly matching drug, and the patient takes just a pill and does really well. This is a different kind of example of how tumor profiling can impact someone. So I met a young man, 16-year-old, actually, I think on the phone talking to his mother, and he was in the car about 2 years ago, and he had a bone tumor that had been sort of scooped out by an orthopedic surgeon where he lives down in, I think, North Carolina. And they had diagnosed it as a benign tumor, but then it came back a year later. And they had sent the tumor around to a bunch of pathologists who really are the ones who make diagnoses, and had sort of some conflicting diagnoses. And we were able to enroll him in our precision oncology trial for solid tumors. And the real dilemma for him was one of the sets of diagnoses he was being given was osteosarcoma, which requires chemotherapy. And the other one was a benign tumor, which doesn't require any chemotherapy. And also the surgery is totally different for those two things. So we really had to resolve this dilemma. So what was amazing is when we got the results back, it made perfect sense. So one of the two genes had changed places. One of the genes was the gene associated with that benign tumor, and the other gene was the osteosarcoma gene. And so we were able to totally understand the fact that the osteosarcoma gene was involved, called P53, meant this was osteosarcoma and he needed chemotherapy, which wasn't a great outcome. It wasn't what he was hoping for, but it's what, allowed us to properly treat him. And it's just to show that, these dollars not only sort of support programs and set standards, but actually directly reach to patients and have a significant impact.
Real world. Anne?
So I can think of a couple of years ago, now it's more than a couple of years ago, but I had a patient who had Hodgkin whose family, she did very well, fortunately, whose family wanted to give a major gift to the institution, and they actually gave funding to Margaret Shipp, the woman I just mentioned, who's really been one of the leading biologists and scientists in sort of dissecting out what Hodgkin is and how we can potentially develop new therapies. And I think that was incredibly important, not only for patients here, but everywhere. I mean, that, understanding that pathway has really been a game changer in Hodgkin.
Jenny, you have one?
Yeah, I can say that early in my career, one of the reasons that I started studying adolescents and young adults is because it was in the interest of a donor, that a donor thought this was a really important area to study, and it was something that I was thinking about doing, and our interests just lined up, and I was able to do some of my first work in this population. And that donation, now we have several major grants from NIH to continue that work. And so that initial work really spurred a lot of later work that's ongoing. The other thing I would say is that the experience of having a donor say that your work is important is really meaningful. That kind of vote of confidence always means the world to me, that there's someone out there who says, keep doing what you're doing. I want to support this, and I want to make sure that your work continues. And especially for young investigators, but really honestly for all of us at all phases of our careers, that experience is really important for some of those late nights or early mornings when we're wondering if we're doing the right thing, and being able to hear from people out there who might have been patients themselves, or who might have had loved ones receive care, or who know something about this experience, to say, no, the work you're doing matters, and I want you to keep going. It means a lot.
Great. Yeah. You must have a zillion.
So, I told you the program story. There's a similar story, but even better in many ways around some of our core research in our program for young women. So, starts out kind of similarly. I was planning a kind of in-person, in-clinic, one person at a time, enroll people because it was going to be all me. And someone, you're young and poor and you can do it yourself because you have more time than treasure. And I was connected with a donor. She goes by Anonymous, and she supported a big kind of hairy, audacious idea, which was rather than just enrolling one person at a time, why don't you start a cohort? That was our idea, but she wanted to support it. And so we decided to start our young women's cohort, which we enrolled for a decade. From 2006 to 2016. And now we're going to follow these women who were diagnosed 40 and under for 20 years. We initially were going to do 10 years, but we got to the 10-year mark for the first part of the cohort. And we said, we're not done asking them questions and they're not done answering for us. It's called Helping Ourselves, Helping Others, the Young Women's Cohort Breast Cancer Study. And so we've published a large number of papers off that. The cohort is just starting to mature. And what's the most gratifying thing is that myself and colleagues are now writing grants off that cohort, including foundation and governmental grants from, again, healthcare delivery and survivorship issues to kind of basic translational issues, because we collected blood and tumor along the way from these young women participants who are giving of their time and literally their bodies. And so it's really been a gift for me as a young clinical researcher, and to be able to collaborate with investigators from all over the Institute and other institutions. And I'm not a basic scientist or a translational researcher, but I get to be a connector. And I get to say, I have this exquisitely annotated data set, and you've got that lab question. Obviously, they come to me too, but it's been a lot of fun. And I think that would not have started without the help of philanthropic support.
So interesting. I'm listening to you, and I know that Jenny Perini is listening to all of us. And I remember, Jenny, sitting down with your mother and father after David died, and they wanted to do something, and creating this whole menu of things to think about. And on the top of the menu was survivorship. And that's as far as we got in the discussion that day. They said yes. And that was the Perini long-term survivorship clinic that started in pediatrics and evolved into both our children and our young adults and our older adults now. So last but not least in my questions for you is, if you think about this field, I mean, we've talked about it as a gap between the children and the adults. The children represent actually childhood cancer represents about 1% of all cancer. And this group of sort of 15 to 40-year-olds probably represents maybe 10% of cancer, 15% of cancer. I'm not sure myself. Where do you think this is all going to go? Or do you think it's all going to meld together and biology will just, sort of trump, if you will, age differences?
So, what I'm most excited about right now is drawing on and expanding this idea of collaboration beyond what we usually think about it. We've talked about collaboration between medicine and pediatrics. We've talked about collaboration between clinicians and scientists. But actually, Jenny and I are very fortunate to be involved in a project that just got, major NIH funding, expanding that collaboration to taking research directly to patients, families, and loved ones, and doing that in a way that's as inclusive as possible. And I really think this is where the power is going to come from. in our field where I study sort of rare cancers in adolescents and young adults in the next 10 years. And I'm really excited about it because it breaks down a lot of barriers. As well as I work together with the medical sarcoma clinic, our patients are still in two separate places, right? So we have to bring the research to those two locations. What if instead we just bring everything right directly to the patient? So we're really excited about that. We're partnered with Nick Wagley, who developed this sort of Count Me In direct to patient engagement platform, and we're bringing that to two rare sarcomas, and maybe Jenny will talk about how she's going to use that to learn more about how we engage people.
Got it.
So I would say the other thing we really need to focus on, I think, we're trying to dissect out, is the biology different, or is this different host? Are they being treated differently? It's probably all of the above to some extent, and hopefully someday for an individual patient we'll be able to sort that out. But I think in the meantime, as that work moves forward, we also have to support the individual patients. I think as Jenny has talked about and Anne has talked about fertility and psychosocial support, and this is a really hard time to have cancer and to be coming to the Cancer Institute, particularly during a pandemic. So, I think we really have to focus on all the other ways that we can support these patients now and to set them up to be successful moving forward. And I think we have a lot of work to do in that realm, but fortunately we have a lot of researchers here, as you've heard about, who are focusing on these questions as well.
Got it. Jenny, we heard a little bit of an intro from Katie. Anything else you want to add to that?
Well, I think I would just add, sort of echo that and say that one of the things that I think we can and need to do is expand our reach. That, we have this wonderful patient population here, but we want to try to help people all around the country or around the world who are in these situations. And so developing models for care, developing interventions that can go beyond our walls are important next steps that I think can really shape the field. We have the kind of people here, as we've talked about, who can make care better, not just for the patients here, but for patients everywhere.
Good point. It actually addresses a query that's in the chat box too, in terms of, how we're reaching out even to our own surrounding community in terms of equity in opportunity for our services. And you get the last word here.
I'm sorry. My mute button and I are wrestling. I was about to reference that comment in the chat as well. I think that's part of our mission. We're all drawn to that. If a tree falls in the forest and nobody hears it except the people locally, that's okay. We really want to get out and take care of our community, both local, regional, national, and international. And that's kind of who we are. And I think that, Dana-Farber is a unique place in that we have good examples of how we've already done that, and we want to continue to do that. And with adolescent and young adults, I think it's really ripe. It's a time that is ready for that, because historically you wouldn't be able to necessarily reach populations. And if we were focusing on really old adults, no offense to anybody, they,
no offense taken.
Yeah, no, I won't count you. But there's a big technology gap, right? But it actually doesn't, it's not so existent. Even in poorer places, the young adults have phones and they have access and they get things through school, at least in the United States. And so, we have an opportunity to make real change in terms of the ability of people to access our services, our research, and our job is to make it accessible.
Good for you. That's clearly a good way to sort of end the presentation part of the panel. Erin, do we have any questions that we haven't addressed from our audience? Here she comes. Hi, Erin.
Hi, everyone. Thank you so much. You did such a wonderful job. It was almost like you were, I don't know if you were monitoring the questions, but you were hitting them as you spoke. Such an inspiring presentation. I hope you did also see there is a really nice chat message from someone who just thanks you for your work. They said, thanks to all of you for focusing on this underserved group. As a 2-time young adult survivor and almost 20-year patient advocate, I'm so grateful for all you do. So I think she certainly said it best. Thank you all. And we can, I think, begin our closing remarks now.
Well, thank you all to our panel. We really appreciate it, and our audience clearly as well. And I'll turn it back to you, Erin. Thank you.
So I think we're just doing some camera and audio switches here.
I see carrots.
I think it's Dr. Glimcher, right? Dr. Glimcher's coming?
Yeah, Deb, if you can put yourself on camera, and then Nancy and Jen.
There you are.
Nancy and Jen, if you can also make sure that your camera and audio buttons are open, we'll bring you back on.
We're all together. Hi, Nancy.
Nancy, and we just have, I think we've done it.
There we go.
Oh my goodness.
This was amazing. Thank you, everyone. It was an amazing afternoon.
It's not as good as being together in person, but I guess we got to make it work and we got to keep everybody safe. Agreed.
I just want to remind you all that content from today's event will also be available on the event landing page throughout from today on throughout the next year. And I encourage you to log back and go into the other sessions. Watch the other content either from this morning or the other breakout sessions this afternoon. Just really appreciate everybody's attention and your continued commitment to our mission at Dana-Farber. And I'm just going to ask Jen to close out.
Thank you. Well, that concludes our committee meeting for this year. I'd like us all to, again, give a big thank you to Dr. Steve Sallin and Dr. Deb Schrag for once again providing their excellent and thought-provoking moderating, and to all of our really prestigious faculty presenters. Every time we have this meeting, I really come away so amazed at these people who have dedicated their lives to ending the suffering that cancer brings. And someone, I think one of this morning's presenters was talking about the humility that is present among this group of doctors and nurses. And I'm always struck by it because, you would never know that they're superheroes because they're so down to earth and wonderful. And anyway, just really appreciate them all so much. And finally, thank you all for showing up despite the limitations of a virtual format. That said, given what we've all heard here today, I imagine you are not disappointed. Our hope is that you take whatever inspired you today and bring that into your communities, so that more people know about the healing and hope that the Dana gives to people every day. I hope the rest of 2020 is safe and sane for you and yours. And we are now going to hear from Dr. Lori Glimcher, who will give her closing remarks. Thanks again.
Thank you.
Thank you so much.
Yeah. I hope you all enjoyed a productive breakout session and the time to connect with one another. Please accept my sincere gratitude for your participation. And again, I would like to thank Dana-Farber's trustee and faculty chairs whose names you'll see on your screen for leading today's discussions. They have diligently taken note of your questions and ideas, and I'm looking forward to meeting with them next week for an executive session to ensure that I am apprised of your questions and your ideas and your feedback. While, of course, we would have preferred to meet in person, as we have for nearly 2 decades for this symposium, one distinct opportunity of this year's format is the ability to expand access to this program to an even wider community. In fact, at the executive session last year, one of the main recommendations from our trustee and faculty co-chairs based on your feedback, was to share this symposium more widely through video and technology to enable even greater participation for those who might not be able to get to Boston. To that end, recordings from today will be available to you and to those who couldn't join us live. As well, the community and resources sections at the top of this event platform will continue to be available in the months ahead, and those are additional ways to stay engaged with each other and to spread the word to others about Dana-Farber's advances in research and care. At Dana-Farber, together, our community is a force to be reckoned with, and we can't ignore cancer. Our together is comprised of you, our foremost advocates, and our physicians, nurses, clinical support staff, whose compassion is a beacon of hope, and our scientists, who are among the most brilliant minds in the world, and children and adults with cancer, who motivate all of us to accelerate prevention, therapies, and cures. Our together is embodied by the Jimmy Fund and our mantra, we're all Jimmy. We're all Jimmy, where Jimmy is every patient, doctor, nurse, staff member, donor, and event participant, everyone who joins to support groundbreaking cancer research and care at Dana-Farber, as you will witness on the screen now to close today's program. I look forward to continuing this conversation. Thank you so much for joining us, and I wish you strength, wellness, and peace to you and your families.
Jimmy is a boy, saved from leukemia by Dr. Sydney Farber. Jimmy is a girl, a nephew, a husband, a wife. Jimmy is every patient ever at Dana-Farber Cancer Institute, their families, friends, neighbors, every doctor, nurse, and researcher at Dana-Farber, every event walker, runner, rider, and golfer. Support the Jimmy Fund and give more and more of us a second chance at life, because we're all Jimmy.